Hello, can everyone see me and hear me well? All right. Pleasure to have you guys. Pleasure to have you. So let's just break the ice really quick before we start our webinar. So my name is Dr. Mohammed. Guys can call me Nat for short. I'm currently a PGY1 gastroenterology resident. I finished my step one and my step two exams last year, scoring 260 in my step two. I've been tutoring for over 3 years now, helping students pass their step one, their step two, and their step three scores as well. So the purpose of today's webinar is basically covering screening, and as much as I can, I'll try to cover important stuff about vaccinations. So the worst thing I do, or the worst thing I see for step one and step two, is that there's no solid concrete source for screening and vaccinations, right? It's scattered all over the place. Whether it's your uworld, it's your amboss, it's your CMS forms, it's your nbmes, you have to solve everything just to cover the concepts of screening and just to have a source to study from. So in this webinar, I'll try to make it as fun as possible, as interactive as possible, and I'll try to brief you guys on the most important high-yield stuff in screening based on my experience when I gave the exam, based on the experience I had from students, and based on what the NBMEs and the actual exam focuses on, right? Is this for step one and step two? Yes, it is for step one and step two as well, because nowadays step one and step two, and even step three, they focus so much on screening and vaccinations, right? I'll try my best to make it as fun as possible. I want you guys to be interactive, all right? I know it's such a bad topic in the sense that no matter how smart you are, you need to memorize your screening and vaccinations, right? Because what I always tell my students are the difference between a 250 and a 270 isn't how smart a person is. It's basically how much they can stop missing marks on easy to get questions. So questions about your screenings, about your vaccinations, about your ethics, about your biostats, basically the questions which need you to memorize before you need to understand. All right. So let's start. All right. I'll try my best to make it as fun as possible, as interactive as possible. If you guys have any questions, feel free to ask me and I'll try my best to answer them as well. Okay. So let's start with screening. Okay. We're going to cover a few different topics about screening, and these are the most high yield stuff. So to start with about screening, let's first convey the topic of colonoscopy, right? So why do we screen people for diseases? We screen people so that we can catch a certain disease before the symptoms happen so that the prognosis is good, right? So in this session, we're going to cover different things, basically colonoscopies, diabetes, lipids, so on and so forth. So when you start about colonoscopies, the average risk individual, the screening starts at the age of 45 years, right? 45 years. And the person is screened every 10 years till the age of 75. Now, why is it till the age of 75, you may ask? Simply because at that age, the risk versus benefit isn't really there anymore. Now, if the person has a first degree relative, right? If the person has a first degree relative with a family history of colorectal cancer or a highly suspicious polyp, then the person is screened at the age of 40 years or 10 years younger than the age at which the family member was first diagnosed. So let's say that the person had his father, he had colon cancer and he was diagnosed at the age of 45 years, right? So if you subtract 10 years from 45, it becomes 35. So now the person is screened at 35 years instead of 40. Why? Because 35 is less than 40. Now, if the person has colorectal cancer or he has a highly suspicious polyp. Does any of you guys know what a highly suspicious polyp is? Basically, a highly suspicious polyp is a polyp which is equal to or more than 10 millimeters in size, or a polyp with features of malignancy, basically serrated edges, high nucleus to cytoplasmic ratio, irregular borders, so on and so forth. Now, what's the frequency of their screening? They're screened every 5 years, once again till the age of 75 years. All right? However, if the first degree relative was diagnosed at more than 60 years, then we repeat the screening every 10 years. All right? Now, In the case of IBD, inflammatory bowel disease, ulcerative colitis, and Crohn's disease, colonoscopies are done 8 to 10 years after the initial diagnosis, and then they're repeated every 1 to 3 years. So, if we recap the whole concept of colonoscopy so far, people are started screening with colonoscopies at the age of 45 years. And then we repeat them every 10 years till the person reaches 75 years of age. The exceptions to that is that if a person has a first-degree relative with colorectal cancer or a highly suspicious polyp, then we either screen at the age of 40 years or 10 years younger than the age at which the first-degree relative was diagnosed. We screen them every 5 years till the age of 75. However, if the first-degree relative was diagnosed at an age of more than 60 years, then we screen them every 10 years. The second step, or the second important point, is IBD. Colonoscopies are done 8 to 10 years after the initial diagnosis, and then they are repeated every 1 to 3 years. All right? Now, in the case of polyps, right, we said that if a person has a highly suspicious polyp, basically a polyp whose size is equal to or more than 10 millimeters, irregular borders, features of malignancy, serrated edges, so on and so forth, they're treated at the same way that the person has cancer, correct? Now, in the case of polyps, we do the screening every 5 to 10 years. So every 5 to 10 years, if that's a low-risk polyp, if that's a low-risk polyp. But if it's a high-risk polyp, then we screen them every 3 years. All right? That's the difference. If they tell you the person has a polyp, but the polyp is a low-feature polyp, a low-risk polyp, basically a polyp whose size is less than 10 millimeters. It's a tubular polyp. It's a polyp with regular borders. It's a polyp with no dysplastic changes. In that case, we screen them every 5 to 10 years. All right? Now, in the case of FAP, familial adenomatous polyposis, screening with colonoscopies, they start at an age of what? Does any of you guys have any clue at what age do we start screening for familial adenomatous polyposis? 35? No. We start screening using a colonoscopy for familial adenomatous polyposis starting at 11 to 12 years of age. 11 to 12 years of age, and then we repeat it annually. Right? So why is this the case? Because familial adenomatous polyposis is a disease with 100% penetrance ratio. 100% penetrance ratio simply means that if you have the genes for the disease, it becomes symptomatic immediately with time. There is no ifs, there's no buts. It immediately becomes cancerous. This is why we have to screen at such a young age, and we do it annually to detect any dysplastic changes. Now, the way that the nbme likes to ask is that they don't simply ask you what age do we start screening. No. They take it a step further and they ask you, when do we perform the prophylactic colectomy? Does anyone have any idea when do we perform the prophylactic colectomy for familial adenomatous polyposis? Late teen, age 20, correct? But the MBMEs like to frame it in a different way. They basically tell you we do it at the age of emotional maturity. So emotional maturity, simply because when the person, when the adolescent, when the teen, when the child are mature enough to realize the implications of such an invasive surgical procedure, right? So in the exam, the keyword is going to be age of emotional maturity. All right? Now, the last thing before we finish the topic of colonoscopies, where does the fecal occult blood test and the FIT test fit into the equation? So we have two tests, right? We have the fecal occult blood test and the FIT test. To simplify them, because a lot of you may get confused as to what the difference is between the two, the fecal occult blood test, the first one, is basically a test which detects heme. Heme as in the pigment in hemoglobin. It's the red color. This is why this test has a lot of false positives, correct? Because basically the person could have eaten beets, or he could have taken a drug such as rifampicin, right? So all of these would give a false positive as to whether or not a person has blood in his stool. However, the FIT test, it detects the globin part of hemoglobin. It detects the chemical part of hemoglobin, and this is why it's very, very specific to blood in the stool. Now, regarding FIT and regarding fecal occult blood test, They're always the wrong answers in the questions. They're almost always a distractor in a question. And this is why never pick them as an answer, right? When are they relevant so that you guys can have an idea? Basically, the fecal occult blood test and the fit test are done yearly, once every year. And if they're found to be positive, then we have to proceed with the colonoscopy, right? The only exception is that if a person is very high risk, right? Very high risk, or he is symptomatic, right? So basically, let's say a person is very high risk, as in he has family history of colorectal cancer. He has familial adenomatous polyposis. He is an old person, right, who has sudden dietary changes or sudden stool changes. Or if the person is symptomatic, iron deficiency anemia due to occult bleeding, or if the person started having dietary habit changes. In these cases, the person has a very high suspicion of having cancer. So we just skip the fit test, we skip the fecal occult blood test, and we move straight on to colonoscopy, right? So once again, let's cover and let's recap the entire topic of colonoscopy so that you guys are thorough with it once and for all, right? Now, colonoscopies, once again, let's go over it quickly. It started for an average risk individual at the age of 45 years or more, every 10 years till the age of 75 years. If the person is more than an average risk, so for instance, he has a first degree relative with the familial history of colorectal cancer or highly suspicious polyp, then screening is started at the age of 40 years or 10 years younger than the age of diagnosis of the first degree relative. It is done every 5 years till the age of 75 years or every 10 years if the first degree relative was diagnosed at an age of more than 60 years. Now, in the case of IBD, the initial colonoscopy is done 8 to 10 years after the time of diagnosis, and then it's repeated every 1 to 3 years. In the case of polyps, we divide them into either a high risk polyp or a low risk polyp. For the high risk polyp, we repeat it every 1 to 3 years. For the low risk polyp, every 5 to 10 years. Okay. In the case of familial adenomatous polyposis, we start screening at the age of 10 to 12 or 11 to 12 years. The USMLE doesn't really want you to know when they start screening, but they do want you to know that it's repeated annually and the prophylactic colectomy is done at the age of emotional maturity. All right? Is it clear? I hope it's clear. Now, let's move on to the second topic, right? So the second topic in our screening is basically diabetes mellitus, right? So we have diabetes. It's a disease which is divided into pre-diabetic, into diabetic, and it's divided into type 1 and type 2, and is divided into fasting blood glucose or glycosylated hemoglobin or the random blood glucose level. When do we start screening for diabetes? George asks if the family member has a highly suspicious polyp. Does it change the management of screening for CRC? Yes, it is. Because if he has a family history with a highly suspicious polyp, then we start screening at the age of 40 years or 10 years younger than the age at which the person was diagnosed. Now, one thing I would like to ask you guys, why do you think that the colonoscopy in the case of IBD is done 8 to 10 years after the initial diagnosis? Why do you guys think we wait such a long time? Does anyone have any answer? Even a random guess. Okay. So basically, we wait 8 to 10 years till we perform the colonoscopy in the case of the IBD, simply because exactly cancer takes time to develop. It's such a slowly progressive disease that doing it annually or every 2 years or 3 years defeats the purpose of doing more risk than benefit to the patient, right? Now, in the case of diabetes, when do we start screening for diabetes? According to the latest guidelines, and I want you guys to know that the guidelines are continuously changing, and this is why we try our best to update the guidelines in our PDFs and in our diabetes, we start screening all adults if they are 35 years of age or more. And we repeat screening every 3 years if the screening tests were normal. What's the exception to that? The exception to that is if a person is less than 35 years, we screen them if they fulfill two criteria. The first criteria is that their BMI needs to be equal or more than 25. Basically, they're obese. And the second criteria they need to fulfill is that they need to have one or more risk factors present. So what are the risk factors for diabetes? Basically, hypertension, coronary artery disease, hyperlipidemia. If the person has a certain ethnicity, increasing the risk of diabetes, basically Hispanic, Latino, African Americans. So if a person fulfills these two criteria of having a BMI of more than 25, which is basically he's obese, and he has one or more risk factors, then we can start screening them at an age less than 35 years. However, more than that, we start screening at an age of 35 if they have no risk factors, right? It's a very simple topic. It's a very easy topic. There's no need to dwell. Let's move on to the next one. The third thing is lipids, right? So lipids are a bit controversial because the guidelines have changed a lot from last year to this year. So basically the guidelines before where we start screening children at an age of 9 to 11 years, repeated again at the age of 17 to 18. We screen adult males more than 35 years and we screen adult females more than 40 years, right? Why do we screen females at an older age? Simply because estrogen is protective. It increases HDL, it decreases LDL. Guidelines have changed now. So what are the new guidelines? The new guidelines for the screening of lipids, and this is very important, right? Is that now every person from the age of 20 to 75 years of age, right, are screened for hyperlipidemia, and it's to be repeated every 4 to 6 years. Right? It's very important that you guys know the new guidelines. If they do ask about children, it starts at the age of 9 to 11 years. However, the child needs to have certain risk factors. A very obese child, a child with a very high hip to waist circumference, so on and so forth, right? Now, a very important question they can ask in the exam is what do you need to diagnose lipids, or what do you need to screen for lipids, right? Do we need to screen them for HDL only, or do we need to screen them with LDL only, or total cholesterol, or triglycerides? Do we need all of them, or do we need all of them, or some of them? What do we need? Basically, you don't need all of them. If you just have two, that's fine. So a question which was on the nbmes was a person performed a screening for lipids, for hyperlipidemia, using HDL and total cholesterol levels. So the question was basically asking, does the person need to be screened using LDL as well? And the answer was no. Why? Simply because using HDL and total cholesterol are more than enough. Okay, so this covers the lipids as well. Now, let's move on to a different topic. We finished lipids, we finished diabetes. To quickly recap, because I'll try my best to make you guys memorize with me. So if you guys would like to have the best usage of this webinar, try to repeat with me as well, or try to write it down so that you guys can go over them once and twice and thrice. So in case of diabetes, we start screening at an age of 35 years or more if the person is an average risk individual, and we repeat it every 3 years if their risk is normal. However, if the person is obese, what is obesity? Obesity is basically a BMI equal to or more than 25. And he has one or more risk factors, such as hyperlipidemia, hypertension, coronary artery disease, so on and so forth. We can start screening at an age less than 35. In the case of lipids, the old guidelines are different. Now it's updated. So basically, any adult between the ages of 20 to 75 is screened every 4 to 6 years. If they ask you about children, we do them between the ages of 9 to the ages of 11 years of age. Now, we're going to move the topic a bit to talk about abdominal aortic aneurysms and aortic dissections. So, abdominal aortic aneurysm. Can you guys tell me what the most important risk factor for abdominal aortic aneurysm is? Immediately, what pops into your mind when you think abdominal aortic aneurysm? Exactly, smoking. The number one risk factor, the most important risk factor, the highest yield risk factor for abdominal aortic aneurysm is smoking, right? So for abdominal aortic aneurysm, we screen any male patient, only males, because they have a high risk compared to females. Any male patient between the ages of 65 to 75 years of age, if and only if they have smoked at least once in their life, we screen them once, okay, using an abdominal ultrasound. So any male patient between the ages of 65 to 75 years of age with a history of smoking should be screened at least once with the abdominal ultrasound for diagnosing or for screening abdominal aortic aneurysm. What is the timeline of smoking? The MBMEs don't ask you. The UWorld doesn't ask, amboss doesn't ask. They don't like to confuse you. They'll simply tell you that the person is a smoker or that the person has a history of smoking. Just that, right? Now, the next topic would be lung cancer. In the case of lung cancer, we don't differentiate between the sexes. We simply tell that any person between the ages of 50 to 80 should be screened with a low dose CT scan, right? If he fulfills two criteria. What are the two criteria? Basically, the person has smoked for 20 or more pack years. And if he quit smoking, he quit less than 15 years ago. So it's very, very important. When we screen a person for lung cancer, we use a low dose CT scan because it's a very high sensitivity and specificity. And we screen them only if they fulfill two criteria. What are they? That they have been smoking for the ages of 20 or more years. And if they did quit, they quit less than 15 years ago. So basically, any question, if a question tells you that the person has been a smoker for 50 years, however, he quit more than 20 years ago, would you guys screen him for lung cancer? Come on, I want answers. I want answers. Would you guys screen him for lung cancer? Mariana says yes. No, exactly. You don't screen him because he does not fulfill the two criteria. If the person has been smoking for 100 years, right, but he quit more than 15 years ago, the nbme, the USMLE wants you to know that you don't screen him for lung cancer. Okay? Now, what's the other exception? The other exception is that if a person has been smoking for more than 20 years and he quit less than 15 years ago and he has several comorbidities that shorten his life expectancy. So, for instance, a person with disseminated prostate cancer, or a person with severe Alzheimer's, or a person with some weird disease that kills within 1 month. Do you think there will be any reason to screen him for lung cancer if he already has a short life expectancy? Do you think there is any logic behind that? No. So basically, if a person has any severe comorbidities lessening his life expectancy, there's no need to screen the person. Mariana, exactly. Yes, Mariana, that's the answer to your question. If they have been smoking more than 20 years and they quit less than 15 years ago. So basically, he can tell you that the person has been smoking for 20 years, but right now the person quit smoking. However, he has only quit smoking for less than 5 years. This means he does not fulfill the criteria. This means you're screening him for lung cancer. Okay? Now, is the pace good? Should I try to slow my pace down a bit? Should I try to increase the pace a bit? Or is everything good? All right, really good. So let's recap so far. We finished colonoscopies. We finished diabetes. We finished screening for lipids. And I told you guys the new guidelines for lipids. We finished reviewing abdominal aortic aneurysms in terms of screening. We finished reviewing lung cancer. So basically 5 topics so far, right? Now, what's the next topic? The next topic is a very high yield topic, which is basically STDs, right? And when I would like, the pace is really fine, but I would like to take a screenshot of the diabetes part. Yeah, for sure. So this is the diabetes part, right? So, STDs. When it comes to STDs, I tell my students a very, very important sentence, which is basically what is common when it comes to STDs. So, for instance, a female or a male have been diagnosed with HIV or chlamydia or gonorrhea or any STD. It's very, very logical to assume that they have encountered other STDs because it's their sexual behavior, it's their sexual activity that have made them encounter an STD in the first place. So it's common sense, it's logical to assume that they may have other STDs. So whenever, and I repeat, whenever a person has been screened for one STD and it's positive, you need to screen for other STDs, regardless of the order, right? So if a person is positive for HIV, you have to screen him for syphilis, for chlamydia, for gonorrhea. If a person is positive for chlamydia, then you have to screen him for HIV, for syphilis, for chlamydia, so on and so forth, right? So in terms of STDs, the number one rule is that they're always screened together. Okay? We always screen STDs together. Now, what are the nuances about STDs? What are the tips and tricks when it comes to screening for STDs? So, number one, chlamydia and gonorrhea, the screening starts from the age of sexual activity till 25 years of age. All right, till 25 years of age. So I don't really care if the question tells you that the person has started being sexually active since the age of 10 years, 11 years, 12 years, 13, 14, 15. I don't really care. As long as the person has become indeed sexually active, we immediately start screening him for chlamydia and gonorrhea till the age of 25. Because sometimes where I see a lot of students get mistakes is that they assume that the person is such of a young age. So why do we screen him for chlamydia and gonorrhea? USMLE doesn't care about that. It simply cares that we need to screen them as soon as they start being sexually active. All right. Now, the second thing is the pap smear. The pap smear, right? The pap smear is basically where we get a brush and we take a smear or we take a brush of cells from the cervix and we screen it for cervical cancer. Why is this the case? Simply because between the uterus and the cervix is what is called the transitional zone. It's basically the squamocolumnar junction between the columnar cells of the uterus and the squamous cells of the cervix. This junction, this point, the squamocolumnar junction, is the junction where a lot of dysplastic activity happens, and dysplasia leads to metaplasia, which causes carcinoma in situ, and then this will lead to invasive cancer. And this is why we have to screen every female for pap smears for cervical cancer. So, screening for pap smear starts at 21 years of age, right? It starts at 21 years of age, regardless of the age of sexual activity, because the transition between the cells does not care about whether you're sexually active or not. It's a physiological, biological way of life, which does not care if the female is sexually active or not. It started till the age of 21 years of age. It's repeated every 3 years till 30 years of age, right? Then at 30 years of age and more, we start screening with the pap smear and the human papillomavirus every 5 years till 65 years of age, if the previous tests were adequate. Now, a lot of you guys will have one question, which is, why do we not screen for the human papillomavirus starting at an earlier age? This has a lot to do with the tropicity of the virus, the immunity of younger females being stronger than older females. So basically, what we found out is that the human papillomavirus has a very low chance of infecting any female below 30 years of age. There are some nuances, there are some exceptions, but the general rule of thumb is that any less than 30 years of age, there's really no use to screen for human papillomavirus unless the person is immunocompromised, right? Which brings us to the next point, is that if a person has HIV, right? If a person has HIV, then we test the pap smear at the onset of sexual activity, all right, or at the time of diagnosis of HIV. So basically, HIV is immunosuppressive disease. It lowers immunity. It decreases the defenses of your body. So any disease, any infection which could cause cancer has a very high risk of causing infection. It has a very high risk of causing cancer. And this is why any person who has AIDS, who has HIV, or any person who is taking immunosuppressive drugs, for instance, he has an immune disorder, let's say systemic lupus or rheumatoid arthritis, the person has had an organ transplantation and is taking immunosuppressive medications. In those three cases, we start screening for the pap smear and papillomavirus at a younger age than what's initially indicated. Why? Simply because in these situations, the person has a higher tendency, has a higher risk of developing the cancer, right? So once again, let's cover the STDs. The first rule is always screen STDs together. If one is positive, screen them all. The second thing is that chlamydia and gonorrhea, we screen them at the age of onset of sexual activity, regardless of the age, and I repeat again, regardless of the age, till 25 years of age. We screen for pap smears starting at the age of 21, every 3 years till the person is 30 years of age. And then every 5 years, we will do the pap smear with the human papillomavirus till the age of 65, if the previous results were normal. And if the person has an HIV or an immunosuppressive disease or is on immunosuppressive medications, then we start screening for these diseases at a younger age. Any questions? Is everything clear? All right. Very good. So chlamydia and gonorrhea at 2 years of age? No, 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 no. At the age of onset of sexual activity till 25 years of age. Because once again, above 25 years of age, the viruses have, or sorry, the bacteria have a very low tropicity for the vaginal cells. And this is why the infection tends to be less compared to the younger age, right? Now, let's sprinkle some cherry on top. Basically, the nose, the easy things, the questions which are easy to get a mark in if you know them. The first one is intimate partner violence. Always, whenever you see intimate partner violence in any question, pick it 9 out of 10 times is going to be the answer, right? Because they really care so much about depression. They really care so much about domestic abuse. They really care so much about violence. So whenever you see a question where one of the answers is screened for intimate partner violence, immediately pick it, and 9 out of 10 times is going to be the correct answer. In terms of vaccinations, it's the same as the inactivated influenza vaccine. Basically, the inactivated influenza vaccine is the only vaccine which can be taken for any age, right? Whether the person is 1 year of age, 2 years of age, pregnant, not pregnant, immunosuppressed, not immunosuppressed, winter, summer. It's basically the only vaccine which you can give it any time with peace of mind. So whenever you see a question with inactivated influenza vaccine, it's the answer. Whenever you see a question with intimate partner violence, it's always the answer. You know. So intimate partner violence, we screen at any visit. Now, what's point number 8? Point number 8 is basically teenagers, right? So teens or minors in USA, they're classified as any child, any adolescent less than 18 years of age. In those cases, we can't really give them any medications. We can't do any procedures except with the presence of their guardians, basically their parents. However, the USMLE, the STEP exams emphasizes 3 exceptions. What are those 3 exceptions? Basically, these 3 exceptions are psychiatry, drugs/substance abuse, and what's the third thing? The third thing is sex, right? So in these 3 topics, basically psychiatric disorders, depression, or any anhedonia. Basically, if the person is abusing some drugs or medications, the onset of sexual activity, the pregnancy. In these 3 topics and these 3 topics alone, you don't really need the presence of the guardian, and you can treat the adolescent as a person who is responsible for himself. And if you ever pick the answer as you need the guardian to be available in the space while talking to the child, you're going to get the question wrong. And it's a very easy question, guys, right? So when it comes to these 3 topics, psychiatric disorders, sexual activity, and the drugs, always know that adolescents can be treated as adults. You don't need the presence of their guardian. Okay? Now, Mariana asks if the pap smear is abnormal, how often do we screen? You screen it every year, you screen it annually, till you have 3 successive negative results, and then you come back to screening it at the normal interval. Okay? Now, in the case of pregnancy, okay, in the case of pregnancy, we will always screen for STDs at the initial visit, and once again in the 3rd trimester, right? At the initial visit and the 3rd trimester. All right? Now, what about newborns? What are newborn children screened for? Okay, because this is a very vague topic. It's a very nuanced topic. So what are newborn children screened for? So newborn children are screened for metabolic tests or metabolic disorders. So basically disorders like galactosemia, right? They are screened for eating disorders. They are screened for autism. Okay. Now, regarding hearing, can any of you guys tell me what is the most common cause of infectious sensory neural hearing loss? What is the most common cause of newborn infectious sensory neural hearing loss? It's not Pseudomonas. It's basically CMV. Yes, exactly. So CMV is the most common cause of infectious newborn sensory neural hearing loss. right? Regarding autism, the screening for autism starts at 18 months and 24 months. And can any of you guys tell me what autism manifests as in such a young age? Like, obviously, the newborn child at 1.5 years of age, he can't speak, he can't play. So, how can we say that the person or that the child is suspicious for autism? Mute? No. Eye contact, exactly. Eye contact. So, eye contact in a person or in a child with autism is very, 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 very little, right? They can't maintain eye contact, and this is why we tend to suspect that they have autism. And the earlier we diagnose them, the better the outcome, the better the prognosis. Let's go about depression. So, in the case of depression, depression is screened twice, starting at the age of 12 years or more, at least once, and then starting at the age of 65 years or more. Okay. So, a question can come to you in the exam, and they can tell you that a 70-year-old man, since a few weeks ago or a few months ago, started becoming socially isolated, started watching TV by himself, started spending less time with his kids, right? These are signs of depression, and you need to screen the person for depression, right? So we screen for depression at the age of 11 to 12 years, and then at the age of 65 years or more. So basically, once when they're young and once when they're old. Now, what's the next topic? And this topic is very, very important. It's the topic of breast cancer. And breast cancer is very important, guys, especially in developing countries, because you never really know at what age breast cancer can develop. I mean, just yesterday, I had a patient at the hospital and she was just 39 years of age, 39 years of age. And she had breast cancer that had fully disseminated to her brain, to her lungs, and to her bones. And she was 39 years of age, right? So, breast cancer is a very important topic for you as a doctor. So, when do we screen for breast cancer? Basically, screening for breast cancer is done every 2 years, all right? Starting from the age of 40 years till the age of 74 years. It's 40. The previous guidelines were 35. The updated guidelines are 40, right? So starting from the age of 40, we screen females using a mammography for breast cancer every 2 years till the age of 75 years of age. Sorry, till the age of 74 years of age. Now, can we screen earlier than 40 years? Yes, we can if the female has risk factors. So, what are the risk factors? The most obvious risk factor is basically family history of breast cancer, family history of Lynch syndrome, family history of male breast cancer or ovarian cancer, so on and so forth, right? Now, when do we screen a female for the BRCA gene mutations? So basically, the BRCA genes are genes which increases a female's susceptibility of developing breast cancer and ovarian cancer and endometrial cancer. But it's not routinely screened for a female. When can we actually screen a female for BRCA mutations? If the female has a family history of breast cancer or a family history of ovarian cancer, and even a family history of male breast cancer. All right? Now, let's move on to the next topic, which is basically osteoporosis. So, when do we screen for osteoporosis? So, we screen for osteoporosis using a DEXA scan, which is basically a bone mineral density scan, at the ages of 65 years or more, and it's repeated. And this is where a lot of students have a weird issue with it. Take very important care. A DEXA scan is is screened at the age of 65 years or more in a female, and it's repeated, all right? It's repeated every 10 to 15 years, all right? 10 to 15 years. However, if the DEXA scan was positive, then we repeat it every 2 years. Repeat every 2 years if positive. So we start screening at the age of 65 years or more. If it's negative, we screen every 10 to 15 years. If it's positive, we screen biannually, basically every 2 years. DEXA scan has some exceptions as well, like mammography. So when can we screen earlier for osteoporosis using a DEXA scan? We can screen earlier if the patient has risk factors. risk factors. So, can any of you guys tell me what some risk factors for osteoporosis may be like? Exactly. Steroid abuse or steroid usage. This is basically one risk factor. Fertility fractures, which are basically old age fractures. Anorexia, or basically low BMI. Ethnicity, but ethnicity is not such an important risk factor. And a very, very, very important risk factor is smoking. Smoking is a very big risk factor, right? So smoking, history of fractures, history of fertility fractures, family history of osteoporosis, steroid use, a low BMI or anorexic patient. Now, the second last topic is prostate cancer. So prostate cancer is one of those cancers where there's really no benefit in screening it, right? If we want to screen prostate cancer, we screen it between the ages of 55 to 69. And what or how the nbmes ask this question is that they will tell you that a person is at the age of 6 years and he comes to your clinic saying that he wants to be screened for prostate cancer. What's the next step? The next step is you can screen for prostate cancer only after discussing the risks and benefits to the patient. Now, why is this the case? Why is prostate cancer one of the few cancers where we don't initiate screening immediately and we have to first tell the patient the risks and benefits of screening before we carry on the screening process? Like, why do you guys think this is the case? The reason is that prostate cancer is a very, 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 very slow growing cancer. In fact, a person can have prostate cancer. He may die of old age before the prostate cancer ever becomes symptomatic, if it becomes symptomatic, right? So this is why the risks and benefits are not there yet. We don't have enough benefits to justify screening every old male for prostate cancer. Why? Because a person may be screened for prostate cancer, he may have positive prostate cancer, and he can live the rest of his life worried about developing symptoms, about having surgery, about having chemo, about having radio, and he may never live his life, and in the end, he would die of old age and not even die of symptoms of prostate cancer, right? Now, about prostate cancer, what is the most important site of metastasis of prostate cancer? I know it's not related to screening, but it's a very important question. Denise, men are so lucky. We are so lucky, yeah, but we suffer from lung cancer. So yeah, something equates something. Vertebrae, bone, exactly. So one of the most important sites, one of the most common sites of metastasis of prostate cancer is to the bone, and specifically, it's an osteoblastic bone cancer. So osteoblastic or osteosclerotic, it's the same thing, which is basically it causes the abnormal formation of new bone. Now, what about screening? What are the two disorders or the two diseases rather, in which any adult individual needs to be screened at least once in their lifetime for those two diseases? Can anyone take a guess? Any brave, courageous individual can take a guess. What two diseases are screened at least once? Hep C, diabetes, hypertension, Hep C, and HIV. So any person between the ages of 18 to 79 years of age needs to be screened at least once in his lifetime, at least once, for either HIV and hepatitis C virus, right? Diabetes and hypertension, we already test them. Like nowadays, whenever you walk into any clinic, you just get tested for hypertension, right? Diabetes is tested at the age of 35 years or more, like we discussed. But HIV and Hep C are not routinely tested, and this is why we say that any person between the ages of 18 to 79 years of age needs to be screened at least once in their lifetime for HIV and Hep C. All right? So this is the first part of the webinar, which is basically screening, right? So to recap everything related to screening, which are the most high yield stuff, like there are other less important stuff about screening, but this is the cream of the crop. This is basically the cherry on top of the cake. This is the most important stuff related to screening. So Colonoscopies, we talked about every single situation of colonoscopies. We talked about screening for diabetes. We talked about screening for lipids, keeping a specific emphasis on the screening guidelines which have changed, right? We spoke about abdominal aortic aneurysms. We spoke about the lung cancers as well. We spoke about STDs in general. We spoke about intimate partner violence. We spoke about depression. We spoke about teens. We spoke about pregnancy, correct? We spoke about the diseases which need to be screened at least once in the lifetime, whether it's Hep C or HIV, correct? What else did we speak about? We spoke as well about the osteoporosis. We spoke about breast cancer, and we spoke about depression, okay? And the pregnant females as well. So, uh, do any of you guys have any issues with screening? I really hope that I summarized screening and that I gave you a very concrete source that nowadays you can study screening from without having to gather resources from every QBank known to person, right? Okay, so let's move on to vaccinations. I'm going to try my best to just cover the highlights of vaccinations because I wouldn't have time to dive deep into vaccinations like I did in screening, right? So, regarding vaccinations, let's use a different color. Let's go with blue this time, right? So, the issue I see a lot of people having with vaccinations are the vaccination schedules and tetanus vaccines. These are the two most important topics in vaccinations where I see a lot of students suffering from, right? So I'm going to cover these two. Before we dive into them, I'm just going to cover human papillomavirus vaccine first, because a lot of people think that the HPV vaccine is an inactivated vaccine. In reality, it's a live attenuated vaccine, and this is why it's absolutely contraindicated in pregnancy. Okay? Now, the HPV vaccine is given starting at the ages of 11 years till 26 years of age. What does the USMLE want you to know? The USMLE wants you to know that basically, if this vaccine is given at an age less than 15 years, then it's given as 2 doses, right? If it's given at an age more than 15 years, it's given as 3 doses. And for some reason, people think that the HPV vaccine is specific to females only. HPV is an STD which can be transmitted to both females and males, and therefore both males and females are given the vaccine. Okay? So basically, HPV is a live attenuated vaccine given between the ages of 11 to 26 years of age. If it's less than 15 years of age, we give 2 doses. If it's more than 15 years of age, we give 3 doses, right? Now, let's do a quick fun activity together so that you guys can freshen your minds a bit. What are the live attenuated vaccines covered throughout your USMLEs, throughout your step 1 and step 2 exams? I'm not going to say anything. You guys are going to tell me. I'm going to write from your answers. So, what are live attenuated vaccines? So basically, we have MMR, correct? We have polio, specifically the Sabin type. We have the oral typhoid, correct? We have the BCG vaccine. We have the, what else? The rotavirus, correct? What else do we have? The smallpox, but it's a historical vaccine. We have yellow fever. No one said HPV, despite me just spending 5 minutes covering HPV. Okay. What else? Live vaccines are there? Varicella zoster, correct? Is a live vaccine as well. Do you guys have any live vaccines? The Zika virus, but the Zika virus is not such a common high-yield thing for the step exams. Okay. Now, what are the vaccines which are safe to give in pregnant females? Because obviously there's no such thing as a pregnant man, so this is why we say pregnant females, okay? So what's the vaccines which can be given to a pregnant female? Tetanus, okay. What else? You don't give rotavirus to a pregnant female. Basically tetanus, the inactivated influenza vaccine, okay? The respiratory syncytial virus, what else do we give? The HPV vaccine, hepatitis B vaccine, and you said the tetanus vaccines, right? You can also give the hepatitis A vaccine. Okay. The COVID vaccine, well, in some cases, it causes side effects, and the USMLE doesn't really care about the COVID vaccine. It just wants you to know that the most high yield vaccines given in pregnant females, which are safe to give in pregnant females, are the inactivated influenza vaccine, the hepatitis A vaccine, the hepatitis B vaccine, the respiratory syncytial virus, and the Tdap vaccine. Okay. Now, let's cover tetanus. So, two things you need to know about tetanus to answer any question correct. Two things. The first thing is whether the wound is a clean wound or a dirty wound. So basically, is it a clean superficial cut using a kitchen knife, a razor blade, or is it a very nasty contaminated deep wound? So basically, a crush injury, a gunshot wound, a road traffic accident, an RTA. So the first one is the wound type. The second one is the state of immunity of the individual. Was the individual a person with a vague history of tetanus immunizations? Or did he complete his full 3 doses of tetanus immunization? Did he take his vaccines, but he completed less than 3? Is he unsure of whether he took his vaccinations or not? So answer these 2 questions, and you can solve basically any question regarding tetanus vaccines correct. Now, a trick, a tip, an advice I like to give my students whenever they encounter any question regarding tetanus is that when you give treatment for tetanus, it's either the vaccine or the immunoglobulin, the prepared antibody. In all of the cases, you always give the vaccine, right? You always give the vaccine. However, the only instance, and I repeat, the only instance where you give both the vaccine and the immunoglobulin is when the person has a very dirty, big, contaminated wound, and the person has less than 3 doses of the vaccine, or he does not remember being vaccinated, or he has never been vaccinated. Okay? So, how do we summarize this? We summarize this by making a table. So, basically, in the table, we have the wound type, which is basically subdivided into one of 2 different parts. We have a clean, minor wound, and we have a dirty, severe, contaminated wound. And then we have the immunity of the person, basically the person's immunity, which is subdivided into 2 different types. A person who has an unknown history, a vague history, he did not take their vaccinations, or the person took less than 3 doses, and a person who has a very clear history and he took 3 doses or more. Now, let's fill in the gaps. We said that in all instances, the person takes the Tdap vaccine, in all instances. So, the tetanus vaccine or the Tdap, the tetanus vaccine or the Tdap, the tetanus vaccine alone or the Tdap, and the tetanus vaccine or the Tdap. So, in all the cases, they get the vaccine. Now, in the first case, where the person has a clean minor wound, right? And the patient has completed his 3 doses or more, then you only give the tetanus vaccine if, and I repeat, if 10 or more years have passed since he last took his booster. So if a person has a clean minor wound, and he has taken his full vaccinations, then you give him the vaccine only if 10 years or more have passed. On the other hand, if he has a dirty wound, but he once again completed all his vaccinations, you give the vaccine if, and I repeat, if 5 more years have passed. 5 or more years have passed. Now, if the person has a clean minor wound and he has an unknown history of vaccinations, he was never vaccinated, he has a vague history of being vaccinated, he took less than 3 doses, then we give him the tetanus vaccine now only. So basically give it now alone, nothing else. However, if he fulfills the criteria of having a dirty, severe contaminated wound, and he has a vague history, an unknown history, was never vaccinated, less than 3 doses, then and only then we give both the vaccine and the tetanus immunoglobulin. Is this clear? Is this very crystal clear? Does any of you have any question, no matter how small it is, no matter how trivial it is? Because it's a very high topic and a lot of people get it wrong. All right. Now, obviously, without me needing to say it, any person with a wound needs to have his hand or his leg or his infection cleaned with soap and water, right? You need to clean it with soap and water, and then you need to do any debridement if any necrotic tissue is present, and then we will move on with the tetanus vaccine, like I said, right? An important thing to know is that all adults get a booster once per year. Okay? Now, let's move on to the last topic of today's webinar, right? Between tetanus, diphtheria, and tetanus, diphtheria, apertussis, is there any preference or difference? The difference is that one has the pertussis, the acellular pertussis component, and one does not. The one with the acellular pertussis is mostly for children. The one without is mostly for adults, because pertussis is not very common in adults as it is in children. The vaccines safe for pregnancy are the hepatitis B vaccine, the hepatitis A vaccine, the inactivated influenza vaccine, and the what did we say? The inactivated influenza vaccine, the hepatitis A, the hepatitis B. You have the Rh immunoglobulin, okay? And what else? I forgot. The tetanus vaccine and the respiratory virus. A booster every year or every 10 years? Every 10 years. Sorry, I forgot to add 10. Every 10 years. Okay, thank you for reminding me. So, would you guys like a very easy way to memorize the vaccination schedule in children? A very easy, simple, straightforward way, once and for all. Okay, so basically, for the vaccination schedule, we have 6 rules. Memorize the 6 rules and you're golden. So we have 6 rules. So rule number one is basically the rule of 2, 4, 6. So basically, there are 5 vaccines given at the age of 2, 4, and 6 months of age, which are the Haemophilus influenza type B vaccine, the diphtheria, tetanus, acellular pertussis vaccine, the inactivated pneumococcal vaccine, the inactivated poliovirus vaccine, the pneumococcal vaccine, and then we have the rotavirus. So the first rule is the rule of 2, 4, 6. At 2 months, at 4 months, at 6 months, we give 5 vaccines at the same time. They are the Haemophilus influenza, the inactivated poliovirus vaccine, rotavirus, the pneumococcal vaccine, and the diphtheria, tetanus, acellular pertussis. So this is rule number 1. The second rule is basically the rule of 1 year equals 12 months equals live vaccines. So basically, at the age of 1 year, at the age of 12 months, we give the live vaccines and we remember it by the acronym Mr. VAR. So Mr. VAR stands for the MMR and varicella. So the M is for MMR and the V is for varicella. This is the second rule. Now, the third rule is the rule of 4 to 6 years equals school boosters. So basically, at 4 to 6 years, we have the school boosters, which are the diphtheria, tetanus, acellular pertussis. We have the MMR again. We have the varicella again. And then we have the inactivated poliovirus vaccine. So far, we have covered 3 rules. Rule number 1 is that 2, 4, 6, we get 5 vaccines, which are the inactivated poliovirus, inactivated pneumococcal, Haemophilus influenza type B, rotavirus vaccine, and the Tdap vaccine. Rule number 2 is the rule of 1 year or 12 months of age. We give the live vaccines, Mr. VAR, the MMR, and the varicella. Rule number 3 is at the age of school entry. At 4 to 6 years, we give the boosters, which are basically 4 boosters, the MMR, the varicella, the inactivated poliovirus vaccine, and the Tdap. Rule number 4 is basically the rule of 11 to 12 years, or the teenage PO, which I like to summarize them in what's known as the THM, right? The high yield material. The high yield material. They stand for what? They stand for the Tdap, They stand for the HPV vaccine, and they stand for the meningococcal vaccine. Okay, this is rule number 4. Now, rule number 5, bear with me, just 2 rules left. Rule number 5 is that the inactivated influenza vaccine is given after 6 months of age. Okay? And hepatitis B vaccine is the only vaccine given at birth, basically given at 0 months or 0 hour. Okay? Rule number 6 is basically any person with asplenia or splenectomy is given the vaccine called SHIN, SHIN. So basically, SHIN, which stand for the Streptococcus pneumoniae vaccine, the Haemophilus influenza vaccine, and Neisseria meningitis vaccine. Okay? So if you guys ever feel that vaccination schedules are very hard, just remember these 6 rules. So repeat it to me once again. Rule number 1, the rule of 2, 4, 6 months. Basically, 5 vaccines are given at the ages of 2, 4, and 6 months, which are the Tdap, the inactivated pneumococcal vaccine, inactivated poliovirus vaccine, the PCV vaccine, and the rotavirus vaccine. Now, rule number 2, at the age of 1 year or the age of 12 months, we give the live vaccines, which are basically Mr. VAR, MMR, and varicella. Then, rule number 3 is that at 4 to 6 years of age, at the school years, we give the school boosters, which are once again Mr. VAR, MMR, and varicella, and we add to them the inactivated polio and the Tdap vaccine. Rule number 4 is at the age of 11 to 12 years, we give the teenage trio, which is the high yield material, THM, which stand for tetanus, hemophilovirus, and the meningococcal vaccine. Rule number 5 is that inactivated influenza vaccine is given after the age of 6 months, and HPV vaccine is the only vaccine given at the age of 0 months, the hepatitis B vaccine. And finally, rule number 6, asplenia, and any person with splenectomy is given SHIN, which is basically Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitis. Right? Rotavirus? Yes. Right? So these are the rules to memorizing the vaccination schedule once and for all. Is it clear? Is it very easy now? All right. So let me have a couple of questions with you, just 2 to 3 questions before we end our webinar. Okay? So let's go over the questions. A 38-year-old man presents for a routine exam. His father was diagnosed with colon cancer at the age of 48 years. He is asymptomatic. What is the next step in management? What do you guys think the answer is? So the child or the person is 38 years of age. However, his father, his first degree relative, was diagnosed at the age of 48. Exactly. The answer is C. Excellent. Okay, great job. Now, let's move on to the second question. A 35-year-old man presents to the emergency department after stepping on a rusty nail. The wound is deep and contaminated. He is unsure of his tetanus vaccination. What is the next step? So this person fulfills the 2 criteria of not knowing his vaccination history, and he has a deep contaminated wound. So this is the only criteria of Tdap plus immunoglobulin. Exactly. So the answer is B. We understand now the reason. Now, let's go over the last question together. A 33-year-old woman presents for cervical cancer screening. She has no symptoms. She has no significant medical history. What is the most appropriate screening method? What do you guys think the answer is? Excellent. B. Why is it B? We said that above the age of 30, we screen for both the cervical pap smear and the HPV every 5 years. We don't screen for one alone. So this is why the answer is A. Brunhilde, is it clear for you why we chose A, not B? Because she's basically above 30 years of age. So above 30 years of age, we screen for both HPV and the pap smear every 5 years till the age of 65 years of age. Right? So, do any of you guys have any questions regarding today's webinar? All right. So I wouldn't be able to talk about rabies simply because we wouldn't have enough time. I'll just give you a very quick information about rabies is that rabies, we divide the vaccination into three different animals. Basically, we have the low risk animals, the rabbits, the hamsters. In this case, we do not give a vaccination. The second thing is that we have domesticated animals, cats and dogs. If we can observe the animal for 10 days. We'll observe the animal for any symptoms. If the animal is symptomatic, we'll give the vaccine. If not, if you cannot observe the animal, if the animal ran away, we immediately give the vaccine. The third situation is that if it's a wild animal, so basically foxes, raccoons, bats, in this case, if we can capture the animal, we euthanize it, we look at the brain, we take a brain biopsy. If there's symptoms of rabies, we give the vaccine. If the animal cannot be captured, we immediately give the vaccine. The only high yield information is that the USMLE emphasizes that bat bites are very missed. People often miss bat bites because they are very weak. They're not painful. So whenever you encounter a bat, even if you don't remember whether you have been bitten or not, it's best to take the rabies vaccine. Okay. So I have had such a pleasure, guys, with this webinar. I hope I summarized every important thing regarding screening and at the same time covering vaccinations as much as I can. I know that they're such a boring topics because there is no concrete resource. However, like I said, I tried my best to summarize everything possible to make you guys a very concrete source, a very collected source from all the question banks and from our experience that you guys have a source to study from. At the Match Guy, we have crash courses every week or so regarding step 1 and step 2, where we have a week-long course every day for 9 hours straight. We cover every single topic with every single high-yield material for 9 hours. And a lot of students benefited greatly about this. If you guys would like to join it as well, you're more than welcome. And if you guys feel the need that you need to have one-on-one tutoring sessions, whether it's with me as your tutor or any other tutor at the Match Guy, feel free to uh, ask the support team for getting in touch with our tutors as well. Some people can seek help where we make you accountable, we give you personalized plans, personalized timetables, so on and so forth. I'm going to send you guys the link of our Telegram group, our Telegram community as well, right? So this is the link of our Telegram community. And I'm going to send you as well a link to our question bank. So at the Match Guy, we have a question bank. I don't know if you guys are familiar with it or not. It's called the Synapse question bank or the Synapse QBank. So what's different is that nowadays we see a lot of QBanks having 4,000, 5,000, 6,000, 7,000 questions. And what's the need of having so many questions, right? When all you need in step 1 is just a pass. People waste so much time on step 1 doing so many questions when all you need is a pass. This is why they have created our own unique, individualized QBank, having the most high yield questions. It's just 1350 questions, no more, no less, not 4,000 or 5,000 or 6,000 questions, right? And they'll help you know the most high yield material in as little time as possible instead of wasting dozens of hours doing questions about low yield material, right? So if any of you guys want the recording of the webinar, because you guys asked for it a lot, so this would be the YouTube channel where you'll find the recording of this webinar and every single webinar which we have conducted before. Once again, guys, I had such an incredible pleasure. You guys are really amazing. I hope you guys do well in your step 1, step 2 exams and eventually match. I hope you guys benefited so much from this webinar. I tried my best to keep it short, concise, and fun. And I hope to see you guys in the future. Right? Best of luck. Bye-bye.